Welcome, everyone. We are delighted to have so many people join us today. My name is Jen Carlo. I'm the program manager for Patient Choices Vermont. And I would also introduce Amy Bruce, who is our executive director, who is with us today. If you'd like to send a private message to either of us in the chat, please feel free to just find our names and do that at any point. Exit Matters is meant to provide folks who attend with some basic information about Act 39 and MAID in Vermont. We're going to do things a little bit differently today. We are going to proceed first with our featured speaker, and then at the end, I am happy to provide our basic MAID presentation for anybody who would like to join us. So please feel free to introduce yourself with your name and your town in the chat so that we can see who's here. And please feel free to ask questions at any time. You can put them in the chat, or you can raise your hand, and when there's a natural pause in the presentation, we can field as many questions as possible. So thank you again for being here, and I am delighted to welcome back Cindy Bruzzese, who's the Executive Director and Certified Clinical Ethicist for the Vermont Ethics Network. She's also a clinical ethicist for the UVM Medical Center, in addition to her responsibilities at VEN, and serves as an ethicist for various other organizations in Vermont. Thursday, I believe, is National Healthcare Decisions Day. And since Patient Choices Vermont and the Vermont Ethics Network have long been partner organizations, we wanted to do something collaborative to acknowledge the fact that this is National Healthcare Decisions time. So the dementia dilemma is a question that is so often raised in all of our programs on the road, in libraries and senior centers, and is also often raised in these monthly Exit Matters sessions. So we were delighted to invite Cindy to join us and share some of her thoughts and expertise on that. So with that, I will turn it over to Cindy. And please remember, if you'd like to stay on at the end to hear a little bit more about Act 39 and MAID, we will do that at the end. So Cindy, please.
Thanks, Jen. Thanks so much for having me, and thanks everyone for being here. It's great to see you, and it's great to see so many people with their cameras on, which is so nice. It's so much more pleasant to see your faces than to be looking at just these blank tiles with a name. So I appreciate those of you who've been gracious enough to turn your cameras on. And I will not be offended if you need to eat your lunch at the same time as well. So please feel free to do whatever you need to do to take good care of yourself for this next hour or however long we're together. I see Diana's here too, so I don't know, Diana, maybe this will be like just a recurrence of our tag teaming. So since some of this content, for those of you who attended our month-long series that Diana and I did with another VEN staff member, this will be a repeat for some of that, but hopefully an opportunity to have a conversation about a topic that I certainly get lots and lots and lots of questions on, as it sounds like Patient Choices Vermont does as well, is this issue of living and dying with dementia, and how do we navigate that and have some choice and options around what that looks like when medical aid in dying isn't an option. And so with that, I'm already sharing my screen, and please do feel free. I don't know how, we've got 67 people on the call so far, so I'm not sure what the best strategy is for managing questions, but I really would like for this to be not just me talking at you, but a dialogue so we can have some questions. So I think we can start. I'll try to have some breaks where we can break for questions, and maybe we can start initially with just folks typing their question into the chat. If Jen and or Amy are willing to kind of monitor the chat, I'll try to do that as well, but sometimes my ability to multitask 3 screens gets away from me. And then hopefully we'll also have time at the end, or I can stop sharing and we can just have more of a conversation where people can use the raise their hand feature. So if does that work for you, Jen, as a way to?
Yep.
Okay.
We're good.
I just want to make sure we have time to hear from people as well. So with that, as you know, and you're all very familiar, I'm sure, with the legal parameters of medical aid in dying, which I think there are 2 basic ones that are the barrier. to why this doesn't work for people with dementia as a terminal illness. And that's because one, you have to have a prognosis of 6 months or less, which certainly would happen eventually with a diagnosis of dementia. But you also have to have decision-making capacity, which is the ability to understand information, to make informed and voluntary choices, to appreciate risks, benefits, and alternatives of options available to you. And one can imagine that with a progressive degenerative disease like dementia, the time where you're at the 6-month prognosis requirement does not align with still having decision-making capacity. And so that's why medical aid in dying is not an option right now without a legal change. It is not an option for people to pursue as an end of life pathway. And so if we don't have that as a pathway before us with this particular diagnosis, then what are the options for having some control and trying to navigate this end of life disease? And so the four kind of things that we're going to talk about today, at least at a high level, because we don't have a ton of time, is we're going to talk about advanced directives as a tool. We're going to talk about this idea of stopping eating and drinking by advanced directive, which I'm going to distinguish from voluntarily stopping eating and drinking. And I do think that people refer frequently to voluntarily stopping eating and drinking, but what they actually mean is stopping eating and drinking by advanced directive, so that when they no longer have the ability to make decisions for themselves, that's when they want food and nutrition and hydration to be withheld. And so that's different than voluntarily stopping eating and drinking when a person still has capacity to make all their own decisions. So I want to just unpack that a little bit. And then we're going to talk about portable medical orders, which are this thing called DNR COLST. And COLST stands for Clinician Order for Life-Sustaining Treatment. So we're going to talk about that a little bit as well. And hopefully that's what you all were here hoping to talk about. Otherwise, maybe we'll go off on some other tangents. So I just want to start a little bit by saying that one of the biggest things people can do to have some sense of how things go when they're diagnosed really with any chronic illness, but certainly with dementia, is to start to plan ahead while you're still have capacity and you're maybe living with the disease early in its stages, or you're helping a parent who's living with the disease or a loved one who's living with the disease early in its stages, is to start to think about, what am I worried about in the future as this disease progresses? What are the things that I'm thinking about? What's important to be able to continue to do as things march along? Because with all of these illnesses, dementia one, but other chronic diseases like lung disease or heart disease, COPD, coronary, congestive heart failure, renal failure, all of these diseases where there's no fix for it, it's going to continue to progress, is to think about, how do I live well with this disease while it's marching along? And where do I want to start to think about carving out some preferences and priorities, or maybe thinking about circumstances that maybe wouldn't be acceptable? When is it that this is no longer acceptable, a quality of life? Because as an ethicist, quality of life is totally in the wheelhouse of the person who's living it. Like as a physician, those of you who maybe are physicians on the call, or if you're a social worker, as a clinician of any stripe, we have knowledge maybe about clinical aspects of a disease process, but we don't have any knowledge about quality of life. We may have opinions, but we can't weigh in on someone else's quality of life. Only you can weigh in on quality of life for yourself. You determine what quality of life means, and it's different for every person. Some people's quality of life is very much functionally dependent. For other people, it's really about being present. For some people, it may just be about being able to communicate in some way, blinking. I think I've told the story before, where I was doing a workshop at a church group, and the pastor's spouse said that as long as he could blink, which blink as a means of communication. So that to me says there's still some cognitive capability happening, but physically he could only blink. That's all he had left. That was still very much a good quality of life for him. And so that's very different from her, who she was like blinking. Oh, good grief. No, for me, I wouldn't want to still be around if all I could do was blink as a means of communication. So again, two people, very different levels of how they define quality of life. And so are there situations for you that would be unacceptable? Is it all about cognitive function? For my dad, it was exclusively about cognitive function. For other people, it may be physical functioning, being able to be independent with eating and drinking, not really wanting assistance with feeding. Maybe it's about living for a prolonged period of time in a hospital because you have complex medical needs that's requiring you to be in the hospital. For some people, that's just not something they ever want to experience. Other people feel very frustrated at the notion of having to go live in a long-term care facility. And they feel like, gee, if that's where I have to live, if I can't live in my own home, I'm not so sure that that's still quality of life for me. And maybe there's other considerations you could type into the chat if there's other things that aren't on this list that you already have started to think about in terms of what quality of life means and when things may or may not be acceptable. So this is one of the first things to start thinking about as if you're concerned about a dementia diagnosis is, if I'm thinking about this, what would other people need to know in order to take good care of me? Knowing that these things are important to me, because that will shape a care plan, right? It's not so much about picking treatments in advance. It's more about thinking about situations and circumstances, and then the medical team is in a good position, given their knowledge of medicine and the types of treatments we have, to be able to then say, gee, if this is the goal, some of these treatments don't make any sense because they wouldn't help to facilitate that goal. And they might also say, gee, these are things that I would definitely recommend because this is definitely will help you continue to achieve a goal that's important to you. Another thing to think about is just scenarios. Again, this is an opportunity to talk with your clinician ahead of time before you're debilitated, before you maybe can't really make decisions for yourself, is to think about, are there circumstances when I wouldn't really welcome medical interventions anymore to lengthen my life? Because I have this progressive terminal illness that I know is going to continue to march along. Maybe if I were to get a pneumonia or some other infection, would I want that to be treated to be cured? Maybe I would, maybe I wouldn't. Maybe it would depend on how progressed my dementia was, whether or not I would or wouldn't want to have those treatments. Maybe if I have other existing chronic conditions that are also marching along, it's not uncommon for people to have more than one thing happening at a time as we're getting older. Would I continue to want standard medical therapy that's really designed to prolong or sustain my life? Or maybe I would want to forego that. And I had a colleague that talks about these types of decisions as off-ramps, and I loved her analogy. She's from California, and she would describe it as a physician, she said, my job is to keep people on the freeway of life. Because in California, I guess they call it the freeway. I've never been to California, but sounds like you're on. She said, that's my job as a physician in general, is to keep people on the freeway of life. And then as a palliative care physician, she said, one of her duties or obligations is to point out off-ramps for individuals who have terminal or life-living disease. So maybe there's an off-ramp that presents sooner than your terminal illness, but maybe that's preferable to living through the end stage of that disease. And she distinguished pointing out off-ramps as being very different from pushing people over the guardrail. And so I just sort of loved that analogy because I think it's kind of accessible to everyone as you're thinking about circumstances when maybe this is an off-ramp that I would welcome versus, and I think particularly with dementia, when you can't pick the off-ramp of medical aid and dying, you need to maybe think about other types of off-ramps that might present themselves and have those conversations with your clinician, with your family, with the people that are closest to you. So everybody has sort of a picture of what you value and has a better understanding of how you are defining quality of life for yourself.
Good so
Diana, do you
far.
have anything to add to this I know you spend a lot of time talking with people about scenarios and thinking through potential off ramps.
Yeah, I all so far so good. You're doing a great job.
So one of the tools we have to sort of guide that maybe conversation, but also to put it down in writing so that people can see it after the fact when maybe you're not as cognitively clear, is to use the tool that we have all come to know about, which is an advanced directive. And yes, Thursday is National Healthcare Decisions Day, and this entire week is Advanced Directive Week in Vermont. So naturally, we're going to talk a little bit about advanced directives. But using advanced directives is a really important tool, and I think particularly so in dementia, because it gives you the opportunity to communicate a lot of that preferences, the priorities, the quality of life kind of factors that make you who you are and make the life that you want to live worth living, gives us an opportunity to see that, to read about it, to know that. So naming a healthcare agent who knows that well and can be that advocate when you can't advocate for yourself is crucially important. If you have someone that you can name, and if you don't have someone you can name, that's okay. It becomes more important then to document all of those things more clearly about your preferences and priorities. It's great when you have an agent because then they can kind of step into circumstances maybe you hadn't thought about or give insights into contemporary issues that maybe you hadn't unpacked fully and we need more information to really understand. But if you don't have a person like that, that still doesn't mean you can't do it. You just want to get more maybe detailed about those quality of life factors, those scenarios that you would or wouldn't find acceptable. And in the case specifically of dementia, we're increasingly seeing folks lean into disease-specific documents, and in this case, a dementia directive. And I think that that is a tool that is out there. I have mixed sort of feelings about dementia directives or any disease-specific document. I think they can be helpful as long as they go with a more general advanced directive. Because just because you have dementia, as we said earlier, doesn't mean you may not have other chronic diseases or another sudden event that could happen. And if all I have is a dementia directive that's so narrowly crafted around a specific disease, it makes it really hard to apply it to a different circumstance. So if you want to use these tools, I'm not discouraging people from using them, only making sure you're adding them into a more broad general document so that we have both so that we can navigate, I think, a little bit more freely around what to do depending on the circumstance, because there's no crystal ball. When we talk about dementia directives, Dartmouth has one that they have available. It's on the website. There's other states. Washington State has one. Vermont does not have a specific dementia directive, although we do have a tool that we're going to talk about that people can use to address one aspect of end of life care relative to dementia. But here, the Dartmouth document speaks in like 3 different buckets. They talk generally about medical interventions and stages of dementia, early stages of dementia, how you would feel about different types of treatments, middle stages of dementia, where you're maybe losing more of your capabilities in terms of memory and function, and then severe dementia, where you're more at the end stage of the illness, where you can make some preferences known about. And keep in mind, everything you put on an advanced directive, whether it's a general one or a disease specific, is a preference. It is not an order. And so it means we do our best to try to honor preferences to the degree that we are able. And this is where the little bit of rub comes in, I think, with any advanced directive, where if you said, I only want a certain thing, period, that may or may not be possible depending on your circumstances. And this comes up, I think, more when we think about location of care, in particular, where someone says, absolutely, I will not go to a nursing home, or I will not go to the hospital. That is a great thing to know, that this is something this person really doesn't desire. However, there may be circumstances where there's no way to avoid it. because the care needs maybe exceed the individual's ability to stay in their desired location. Like their preferred location really is to be at home for most people. But sometimes we can't make that happen because of a variety of reasons. Usually it's a level of care that's necessary for this person to continue to be safe, and to be comfortable and to have their symptoms managed. So that's the only thing I would just caution people is whenever you're filling out these documents, these are preferences. They're very important because it does help us start to think about the directionality of the care plan and where it should go. But it's really hard to enforce all of these things all of the time. And that's just a function of we don't always have the ability to direct exactly how the disease is going to manifest over time. We just can't know that perfectly in advance. And the only caution I would say, and I've had people that have come up to me afterwards, is when you're filling these out, generally we're always filling them out from our own perspective, but I would invite you to sometime just think a little bit about the perspective of the person or people who are caring for you. Because, my dad was a perfect example. He said absolutely did not, he didn't talk about treatments at all, and he didn't have dementia, but he said he didn't want a wake or a viewing. Like he didn't talk about anything that was going to happen in between before we got to the point of wake and viewing. So there's that dilemma with the document overall. But one thing that was interesting to me is a funeral director once told me, he said, it's kind of a problem because sometimes people haven't seen someone for many years even because they don't live close, and then they die. And then they say no wake, no viewing, nothing. And we have people coming who need to see this person to sort of say goodbye in their own way. And they're denied that opportunity because we have a document that says absolutely not. And so something to think about, like, yes, it's important to know that about you, but would you be okay with it if it meant your loved one would have less complicated grief? Maybe. So sometimes I just invite people to think about these documents, surely predominantly as an expression of your goals and values, but maybe sometimes just to invite the lens of how would this be for my loved one to experience having to do this? Would they be able to? And would it be important to them to be able to see me maybe one last time? And I mentioned this to my father after a funeral director spoke to me, and he said, oh, well, I'd never really thought about it that way. So yes, I think it's fine if you must as the family, but I don't want a whole parade of people coming through and looking at me. And I was like, okay, that's fair. So it's just an interesting lens that I hadn't really thought about until I spoke with the funeral director who was kind of living it on the other side of seeing these families that were really struggling. So just think about this in terms of, is this really doable? And if it isn't doable, am I going to allow my agent some latitude to be able to do what they need to do to take good care of me, even if it may not be perfectly what I wanted? It may be what's necessary due to the circumstances. And the last piece of it that I think is the piece that most people are leaning on dementia directives for, which is how can I force an off-ramp that isn't otherwise presenting itself, right? I'm not hooked up to a machine, so you can't turn the ventilator off, which we all know anyone can do that. I don't require artificial nutrition and hydration because we know we can say no to feeding tubes in advance. Anything that's artificial or mechanically done, we can say no to all of those things. I don't have an implantable cardiac device that I could turn off. Like some people have off ramps, but sometimes there isn't one. And so can we force an off ramp? Medical aid in dying is an off ramp, right? Where we select a time and a place and we obtain prescription for medication intended to hasten our death. That's the plan within the framework that Vermont allows. The other option is that people are looking to, and they've been looking to this long before we had medical aid in dying as a legal option, which was maybe I can stop eating and drinking. Maybe that would force an off ramp because it's not so much the eating, it's really the hydration that is the hastener of end of life. Maybe I could forego that. And so this is a way to document that preference depending on where I am in my dementia. And I would argue that doing this through an advanced directive is generally only really doable when you're here at the very end stage because it becomes much harder to operationalize here in the earlier stages. unless you're voluntarily stopping eating and drinking. But this is really what people are trying to do, is to say, I have nothing else to forego. And so this could be the off ramp that I could take if I stop eating and drinking. And then how do I go about doing that? This document is one way to indicate that preference, but it may not be enough to make it actually happen, because people are interesting beings. And maybe you'll be saying something different at the time when your dementia is actually presenting and saying, I'd really like a piece of pie, or I'd like that scoop of Haagen-Dazs right now, or I'm really enjoying my life, even though I don't remember any of the people that I've known all of my life, but I've got a whole new set of friends here in the long-term care facility, and I'm feeling quite happy here. Or for other people, they may just be really paranoid and anxious and worried about all kinds of things and really, really struggling with behaviors because they're quite agitated, but they're demanding food. And so then it becomes much more challenging to operationalize this type of a plan. Not saying you can't do it, but just recognizing that it's not as easy as just saying it in this sort of a document. One tool, and so this is where we're in this space of using advanced directives to determine when to stop feeding someone. And that we refer to as stopping eating and drinking by advanced directives, or SAID by AD. And so I just want to kind of have these definitions up there for you to sort of unpack this a little bit more. So stopping eating and drinking by advanced directive is a process that allows someone to put instructions ahead of time in your dementia directive or regular directive about sometime in the future when you don't have capacity and you have a predetermined, you've already discussed at what level of deterioration or discomfort is when you want to have food and fluids withheld. And that's your strategy for creating the off-ramp for hastening death. That's different than voluntarily stopping eating and drinking, because when you're voluntarily doing it, you're doing it at a time when you have complete decisional capacity. And so you're way farther upstream than when you're quite debilitated. You're much sooner in the disease progression, and you have to then, which means you're probably more robust and physically healthy. But you're making a choice at a predetermined time as well for when you're going to voluntarily stop doing this. And this is, I think, more difficult in some regards because you need to have a lot of resolve to do it. And this is when you're voluntarily hastening your death by stopping all intake of food and fluids. And people are doing this. So I'm not saying that people aren't doing it. They are making choices. It's just this can be harder to do because you may have a stronger desire to eat, because your disease is much earlier on, and the support of family and clinicians and a team is generally recommended. SAID by AD does not leave the caregiver open to homicide. No, it does not.
And the one above it, Cindy? Yeah, there's another question above it. Are there good definitions of the 3 levels of dementia you were just referencing?
Yeah, there's a bunch of resources, and I can pull those up separately on a website that really try to define more clearly the various different stages of dementia. I think they're not as always crisply defined in practice. And I'm seeing Diana nodding. So I think that there's a general description, and there's a couple of different websites that have that and all. And even in the Dartmouth Dementia Directive, I didn't put that up there as well. They attempt to define the various different stages. I think that they don't always present that way in real time for people who are living with dementia. I think the lines are much more fluid and gray, but we can talk about that. And I can pull up some resources, or maybe somebody, I don't know if we have clinicians on the call who want to give the key markers now. I'm happy to do that. Diana, do you have those in your mind, sort of the key markers of the different stages? I appreciate that they are fluid.
Yes, I think that's really the most important point, is that how a healthcare provider who is seeing you in the emergency room defines your level versus how you define it based on what kind of symptoms of dementia do you find acceptable and unacceptable? I think it's probably important to be clear. Can you walk? Can you live alone? Do you need someone to stay with you all the time? Are you able to recognize your family? I think using specific parameters of what you would find acceptable or unacceptable makes it more easy to understand your particular values, because the stages, they really are interpreted differently by different people, except when it comes to hospice criteria and being clearly in that less than 6-month prognosis, which for many people is a fairly advanced stage.
Since we're
Thanks.
bringing Diana into the conversation, let's just take 1 minute, please, if we could, to introduce you, Diana. Dr. Diana Barnard is a founding board member of PCV, has been instrumental in the passage and preservation of Act 39 since for more than 20 years, and has done a good deal of speaking and advocacy in other states as well. She is a retired palliative care physician and associate professor, I believe, at the UVM College of Medicine. And Diana, is there anything else that I left out that you would like to say about yourself before we go on?
No, nothing except I'm not quite retired, but I like that. I like that hope. Yeah, in the near
From my
future.
mouth to someone's ears.
Yeah, Cindy, I'm also just going to say about the comment for the question. Someone was questioning the concept of voluntarily stopping and eating and drinking by advance directive, and I do think that there is some nuance. There could potentially be nuance by different states that we might not be aware of, and especially the issue of if people are in a skilled nursing home or some kind of facility, just if you want to speak to the nuance or the fact that a facility may have a
Yeah.
different perspective than an individual's patient and family.
Yeah. So one of the aspects, I mean, this voluntary part, and the reason I bring this up is a great question, is that to have decision-making capacity, like by definition, right, includes voluntariness, right? Which is part of what medical aid in dying has as your self-administration of the medications if you're accessing medical aid in dying is your ability to demonstrate voluntariness, a voluntary choice to pursue it and to do it, right? That is the big crux of the problem. You can't voluntarily stop eating and drinking if you, by definition, do not have capacity anymore to make that choice. So that's why it's not called voluntarily stopping eating and drinking by advance directive, because it's no longer voluntary on your behalf if you're the individual. If we're looking at an advance directive, because now it means you don't have capacity to make decisions for yourself, therefore you're not voluntary anymore. And someone else is in charge of making decisions on your behalf that you can no longer make. So that's really the distinction. There's a question here about what is a person's quality of life like when they're embarking on voluntarily stopping eating and drinking. I think it's about timing. I haven't actually been with people who have chosen to do this, although they are out there. I think that it can be challenging. Timing probably does make a pretty big difference. How there's recommendations of maybe starting to limit your nutritional intake ahead of time so that the desire to eat is not as strong as it would be otherwise if you were eating, lots of food ahead of time and then all of a sudden you stop. It's much harder to do. There's a presentation that I did with a couple of clinicians last year on voluntarily stopping eating and drinking that really talked about the process and how to go through it. But it does require some resolve, right? It does require some personal resolve. There's people that have made videos of themselves who were to remind themselves of what their goal is and why they're doing it. Because once you stop eating and drinking, there's a period where your capacity starts to be impacted, right? Because you're not taking in enough fluid and nutrition. And so having the reminders, having family that can remind you of your goal, of what it is you're trying to do, ways of operationalizing that. So, and working with a clinician and having hospice who can address symptoms related to sort of dry mouth and all of those things is crucially important. So it really does require a fair amount of planning. Any of this, either of these options requires planning, but certainly if you're doing it voluntarily, lots of support and lots of planning because you're more healthy, you're more robust, you're still able to make complete and full decisions for yourself. So it does require the preparation and some thought about timing. And so I think it really does need to be done in partnership with a team, a supportive team that includes your clinician, your family or friends, and hospice, and when to make that referral so that you can continue to be supported through the end of life, optimally supported. I think that was one. Yes, great. Thank you for putting that VSED handbook. That was a resource. And on the presentation on the Vermont Ethics Network website, we have all the slides and we have a whole list of reading material and resources at the end too, if people are interested in learning more about voluntarily stopping eating and drinking. And someone asked a question earlier on, I see in the chat about whether even in this state is stopping eating and drinking, is the caregiver open to homicide? No. There does need to be documentation, which is where an advanced directive also really comes into play. It's very helpful. This was an intended plan that the person had relative to hastening their death by not being spoon-fed. At that point, that's usually what it's about, because you can forego artificial nutrition and hydration. That's not even in question. It's really about being supported with manually eating when people who can still eat but just need the assistance because the coordination of doing that is now no longer there due to their disease process. But there's no ability to force feed people. That's the other thing, is we have no ability to make people eat. And I get that question a lot as an ethicist in the hospital. Like, the person's not eating enough. We can't make people eat, right? And so if someone decides it's legal in every state to stop eating and drinking, there's no law against it because we don't force feed people. That's akin to torture and completely not ethically allowed. But the law doesn't say anything about whether or not you can or can't. It's mostly silent, and therefore there's nothing to prevent you from doing it. But I think having good documentation that this is a plan is definitely helpful, because it certainly is something that we're looking to as to why we're pursuing what we're pursuing in terms of no longer really supporting someone with that activity of daily living, which is to eat, because they don't want it. They do not want their death prolonged. And they're seeking to hasten it by foregoing that assistance with eating and drinking. I'm trying to think, did I answer, will healthcare people honors head by AD? Well, that's the $100,000 question. Yes and no. And that's just the truth. Yes and no. And so really being aware of, if you're going, particularly in a long-term care facility, they have very clear and strict requirements around eating and drinking. And it's really more about activities of daily living. They have a statutory requirement to assist individuals with activities of daily living, and eating and drinking is an activity of daily living. They absolutely can't force you to get artificial nutrition and hydration. That's clear and well documented in law that you can forego that. But the assistance with eating manually and drinking is different. It's categorized as an activity of daily living, like getting dressed and, using help assistance with toileting, all of those things. And so they have a responsibility to assist people. And so again, this is where having documentation in an advanced directive, which is a legal document, about your preferences to not have assistance with that becomes critically important. And I think this is where Vermont in particular maybe has a tool that has a little more teeth than just a general dementia directive. And this is what we call a Ulysses clause provision in an advanced directive. So in Vermont, there is, and I've put the statutory reference there as well, there is a provision that allows you the ability to permit your healthcare agent. So that's first criteria. You need to be able to name a healthcare agent. If you don't have an agent, this would not be available to you. Who would, in the event that the principle is how the law refers to the individual, the person, the patient. When they lack capacity, they can authorize the withholding of healthcare over the person's objection. And they can also authorize doing something that this provision, it's called the right to request or object to treatment. So it works in both directions. So it could be that normally I would say yes to this thing, but now that I lack capacity, I'm saying no, and I'm authorizing my agent to give it to me over my objection. But in the case of dementia, I'm saying no, I don't want this. But then when I lack capacity, I'm asking for it. But now I'm authorizing my agent to not give it to me, even though I'm asking for it when I lack capacity. Does that make sense? Because it works both ways. And the initial intent behind this provision, I think I wasn't around when it was being created, but it was really more intended for people with psychiatric illness. That was the framing. So you could imagine a person with, let's just say, schizophrenia, an acute psychiatric condition, who is normally taking their meds and living well and doing well. And then they decide that they're doing so well, they don't really need to take these meds anymore. I don't want to be taking all these pills. I'm not going to take these meds anymore. So they stop taking their medications that are keeping them very stable and doing well. And when they stop taking those medications, their psychosis starts to come back. And now all of a sudden they're acutely psychotic and they end up in the hospital. But they're saying, no, 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 I don't want those medications because they totally lack capacity. And they're saying, no, I don't want these medications. If they had a provision like this that spoke to their acute psychiatric illness and they stopped taking their medications, they could say, listen, if I get to a state where I'm back in the hospital because I'm not taking my medications, I'm authorizing my agent to allow you, the healthcare team, to give me my medications, even if I'm refusing. So that was the initial intent, but it works the other way. And this is how I think people have operationalized this provision for the very reason that we're here today, to forego around eating, which is someone says in their advanced directive, listen, if I'm at this stage of dementia with this level of debility or cognitive decline, and this level of close to end of life, I'm authorizing my agent not to say no to assisting me with eating and drinking, even if I'm asking for it. So I no longer have capacity. I'm telling you now, while I have capacity, my now self, while I have capacity, says, listen, I don't want to be fed under these circumstances. I do not want my dying prolonged by you continuing to feed me. So when I get to this stage, I'm authorizing my agent to no longer feed me so that my death will be hastened. Even if I ask for food, don't give it to me because I don't want it. I don't want my dying prolonged. This is the provision that allows some legal ability for you to enforce that type of a do not spoon feed or do not assist me with eating request. So we have that in our law. Those standard dementia directives don't have anything like this, right? It's just a preference. Here, it's more than that. It requires some certain elements. As I said, first, you have to have a healthcare agent who signs and accepts the responsibility. So this is different than your regular advance directive. Your agent doesn't have to sign your advance directive anywhere. But if you have a provision like this, your agent literally has to sign. They have to sign the document. It has to be specific to what the treatment that we're talking about. And in this case, treatment is food. And it has to be a very clear statement that the person wants or does not want that, even if they are requesting it or objecting it, right? They have to state it very clearly. It has to acknowledge that you have to sign. So you sign again on this provision. The person is signing saying, I'm knowingly and voluntarily waiving my right to refuse or receive treatment at a time of incapacity. So I'm doing this ahead of time while I have capacity. Your clinician has to also sign it because they have to have an informed consent conversation with you that talks about, do you understand the implications of this decision? Do you understand what it is you are waiving, your fundamental right, and that you agree to these conditions? And then your clinician has to sign it. And then not only do we have to have your agent, you and your clinician sign this little provision, there has to be an explainer. This is like a third party person. It can be a long-term care ombudsman, so someone working who goes to long-term care facilities. In the case of mental illness, which this is not for dementia, we do have a special type of person who does this for people who are doing these kinds of provisions in the psychiatric context. can be a Vermont licensed attorney or a probate court designee. I would say, practically speaking, it's either going to be an ombudsman or a licensed attorney. Probate court designees are not readily available, if available at all, depending on the county. And they have to affirm that they have explained the whole provision to you and that there's nobody's forcing you to do this. There's no undue influence, or you're not under any duress when you're completing it. So and the reason is it's a big deal. You're waiving this fundamental right that you have to change your mind, even when you lack capacity. People have the right to change their mind anytime, even when they lack capacity, and you're waiving it. And so that's why it's a big deal. And that's why there's more signatures and signing and protections that are built in to make sure that people really do understand what this means. And this is truly what they want. Any questions about this? I'm just looking to see if there's anything else that's popped up.
The only other thing that was in the chat, I think you partially answered it. Someone asked about, in a care facility setting, are families generally bringing their person home, or are they battling a myriad of caregiver opinions and opposition? I think you partially covered that.
I think it just depends on the facility. I really do. I think it depends on the facility. Some facilities will support people in doing this. Other facilities won't support people in doing this and would almost require them to take the person home. So I think there's wide variability. And if this is something that's important to you, or an option that you want to like have available, like just to know that it's an option, and you're planning and thinking about it, if I have to go in a long-term care facility and you're looking at them, ask, what's your stance on this? Because knowing it ahead of time is helpful, because it may impact which facility you choose to go to. I see, it doesn't give me the order of hands, but I saw Diana's first, so I'll do Diana, and then whoever is Zoom room, I'll do that second.
I was just going to add again the understanding that there is a broad range of values about how much progressive dementia would be acceptable and what you would find as a reasonable quality of life. And remember that those care facilities are going to be thinking the same thing, so that these are very nuanced and careful conversations where you have the ability to be clear about your values and asking if there is room to respect your values just as they respect the values of people who may be in a very different place from you. The other topic I just wanted to at least give people the idea to think about is the use of oral high-calorie supplements like Boost and Ensure and Magic Cups. And I want to just say that in many people and many care facilities will use these high calorie things, whether you call them a basic nutrition or whether you call them a form of artificial nutrition, may depend on your perspective and your circumstance. But it is a way to get a lot of calories in a very small volume. And in my professional opinion, they absolutely can be life prolonging if that's something you want. And so it's just another thing to think about as you're dealing with a progressive illness, is a kind of high calorie oral supplement that you drink yourself or somebody can help you with. Is that something that you want and that's good for you, or might that lead you more to a place that you don't want to be? So it's an important topic. This stuff is all very complicated.
It is complicated. It's a lot to think about. And then who had your hand up in Zoom room, and then I will respond to the question or comment in the chat.
I don't know if this was covered. So we were talking together here in our room. And is there like a differentiation? Like if someone has said to me, like, let's say it's my mother, that once I've reached a certain stage, I want food to be withheld. I'm just thinking, if I put some food in front of her and she was able to somehow feed herself, if she said to me ahead of time, like, you have to withhold food if I need a catheter or something like that. So then she gets to that point and now she's hungry and she's indicating that she's hungry. Is the expectation that the food is still going to be withheld? Like, just like you were saying, like if with someone with mental health issues, they change their mind. Yeah.
That's the challenge, right? So I think with the
Right,
Ulysses Clause provision, the goal of the person, I mean, this is where the conversation becomes hugely important, is we're
right.
asking if someone's saying to you, if I'm the agent and my mother's saying just what you said to me, listen, this is the criteria where I want you to withhold food. I want to ask, what if you're asking
Mhm.
for it?
Yeah,
Like, I want to
yeah,
ask that question because I
yeah,
think it's
yeah.
hugely important to really understand, for everybody to understand what the goal is, because it's going to be, this is the challenge, right? It's easier said than done. Like, I can have a great Ulysses Clause provision. I can have everything, what I think is a really ironclad plan. And then I present differently. Like, I start saying different things. And so it's about,
Right.
how do I go about operationalizing that plan? Can I do it perfectly? Probably not. If not having food, if I'm really hungry and I can't be distracted, and you can't, don't forget, if it was voluntarily stopping eating and drinking, you might have a better shot at reminding the person of their goal. But now that
Yeah,
their brain is failing due to this dementia process, you probably can't have a rational conversation with them, and all they know is they really, really, really want the chocolate chip cookie. Like, I'm sorry, I
right,
want the cookie.
right,
Am I going to really withhold it and get them all agitated?
right,
Probably. I mean, I'm just saying, practically speaking, probably not. But maybe what they're
right,
going to do is we're going to shift into a care plan that's really like, if we can distract and,
mhm,
not be giving them high calorie foods, maybe they have a bite of this,
right,
a bite of that
right,
occasionally. But eventually, it's more of a slower progression to not eating and drinking than what maybe they had hoped for, but it's the plan we can actually do that isn't causing them even more distress. Because
right,
certainly as an ethicist, my goal is not to harm people. I'm okay with this as
right,
an ethicist. I think this is absolutely fine to do. I think there are
right.
some practical realities about how it gets operationalized that you can't always plan for. And so, and again, in long-term care settings, even more. At home, maybe different, maybe have a little bit more latitude to negotiate this in a long-term care
Yeah,
facility when your agent's not the one that's there all the time,
right,
helping to sort of remind the person or distract the person or redirect the person away from food. It may be that they do get a bite of pie and they do have a little bit of a taste of this or that, but the focus is absolutely not on survival and giving them a balanced meal or nutrition. It's really about,
yeah,
sometimes people just want to taste something, right? They
right.
just need to have a
Exactly.
taste.
Right,
And so again, this is the conversation that needs to be had ahead of time, where again we're thinking of, we want to respect the person, but also for the person who's making the decision is, am I okay with my family saying, listen, mom, if you're begging for the cookie, I really want to be able to give it to you because I don't want you to be distressed, and for you to maybe have
right,
that discussion ahead of time.
right.
So
Well
I do want
said.
to, yeah, I do want to respond to a couple of questions. One, which is about the body releasing endorphins and pain receptors. Yes, there's a natural process that happens in the body um, where not having food and not having hydration causes sort of a metabolic shift where your body produces these things that are analgesic in nature. They make you feel better. And so it's part of a natural dying process, which is why people, when they are closer and closer to dying, don't eat and drink. Like, they stop eating of their own. Like, it has the disease processes too. They have no desire to eat and drink. So obviously, the closer you are to initiating this when your body is already starting to shut down, the easier it is. The earlier you're trying to do it, when you still have a lot of desire to eat and drink, it's going to probably be a little harder at the beginning while your body is starting to not really be demanding or wanting, desiring those types of foods. But yes, I don't know why there's not a lot of talk about this. But it certainly is documented in the literature that there are natural processes that are happening metabolically when you stop eating and drinking that provide some of the pain and symptom relief just naturally within the body. So in general, this is not considered a painful way to die at all, even though I think we have sort of, people talk about starving to death, like they have it comes across with sort of a negative connotation, where I think for a lot of people there's no natural desire to eat, is that they're not in any discomfort. And so it's worth having that conversation too with your clinician. How common are you We need more education. How common are Ulysses clauses across states? Oh, not that common. I haven't done a survey in a while about how many states have similar provisions. But there's no provision like this, I know, over in New Hampshire. Like, Vermont has this option. Some states also have it. Minimal comfort feeding. Yes, there's a whole article out there about minimal comfort feeding. Diana, you just made that mention. That is also kind of what we were talking about earlier. But it's nice to know that if there's documentation in advance directive that this is the goal, like this is the plan. I think that's really helpful, and it helps people to then try to proceed with that in the mindset that this is what the person's wanting. How can we make this or get as close to this as possible while still maintaining a certain level of comfort, and not adding burden to someone at the end of their life. Okay. We were getting really close on time, so I just want you to see what the form looked like. It's found in the long form advanced directive. So if you were looking at a long form, go to the part 6. That is the section you want. You could pull it out, and just like a dementia directive, you could attach it as an addendum to a regular advanced directive. You don't have to use the long form. Vermont allows you to use any form you want. So if you say, oh, gee, I'm going to have a regular short form advanced directive, and I'm going to have an addendum to it that speaks more specifically to, this would be like your dementia directive, where I'm pulling out this section and I'm making some very clear statements about my preferences, and I'm going through the process of having this clause with all the signatures. So specific treatments, you're waiving your right, you're signing it, and then the second part of this is the agent is signing it, the clinician is explaining it to you and doing informed consent, they're signing it, and then the explainer's signing it. If you have one of these filled out and you don't have all these signatures, it's not valid. It must have all these signatures to be valid. I see a lot of documents come in where it's filled out and these things aren't signed by anybody. And great, but it's just like a dementia directive with no teeth, because we haven't gone through the legal process that's required for this to be valid in Vermont. It's still information. It tells us it's about their preferences, but it's not valid under Vermont statute. And so this is just a quick summary about where these documents might be helpful. Definitely if someone has, I think behavioral disturbance is where we see it the most, where people are they're having a lot of agitation. That may be one of the criteria that you use as one of the factors this is when it's time to start to do this, because I don't want my dying prolonged in this agitated state, right, of suffering. Maybe you want to slip the medicines in covertly. You could use it that way, where someone takes oral meds and they won't take them to be calmer. But yes, I could. This happens frequently for people with behavioral disturbance with dementia. And then for this said by AD, this is the other way to do it. The limits to this are you have to be specific. So you can't just generally say when I have dementia. That's not good enough. You need to be quite specific about the circumstances when you would do it. You can't just broadly say, I fill one of these out broadly, and anytime I'm refusing or doing something, I let my agent override me. It doesn't work like that too. It has to be specific. It doesn't allow you to plan for when you might revoke your healthcare agent. So keep in mind, people with dementia sometimes don't remember the person they named as their healthcare agent, and they may say, I don't want that person making decisions for me anymore. They can do that when they have dementia. So this would not be a way to sort of plan for that in advance. And it also doesn't allow a hospital to hold somebody who's otherwise medically stable because they can't be cared for at home. This doesn't protect against that. So this is, again, limitations of its use. And I know we're at 1 o'clock, but the only other thing I wanted to chat about was make sure that in the conversations and your planning of advanced directives and you're thinking about all these things, have appropriate uses of portable medical orders, because again, there's no guarantee that dementia will be the off-ramp. Something sudden and unexpected could happen, and making sure you have orders in place where you could limit aggressive medical intervention can be an off-ramp that presents unexpectedly that would allow you to forego a prolonged dying process through dementia. And so this is when it's appropriate for anyone to think about these types of orders. Serious or life-limiting illness where death in the year would not be a surprise. So again, towards the end stage of a dementia diagnosis, and making sure that we're clear that we're foregoing something regardless of the reason it happened. So your heart maybe isn't stopped because of dementia, maybe it's stopped for a totally different reason, but that's okay. That's the off-ramp I want to choose. And these documents, I think, are hugely important. Anybody undertaking SED by AD or voluntarily stopping eating and drinking, or medical aid and dying for that matter, should have appropriate medical orders in place to ensure that they are protected from getting a treatment that they really don't want, especially in that emergency situation.
Cindy, there's one question in the chat that we missed. Would you speak about a scenario of SED by advanced directive when a person is at home and in hospice? What kind of comfort care might be given in that situation?
Yeah, in that situation, I might defer to my clinical colleague who's a hospice medical director who can talk about exactly what hospice is doing for folks like this. But it's definitely around, I think, dryness of mouth. Like, I think mouth care, oral care is hugely important for people that are foregoing nutrition and hydration in particular. And it's sort of anti-anxiolytics, things like that. I think that would help people feel more of a sense of ease and less distressed. Diane, I don't know if there are specific other aspects of caring for someone who is not eating and drinking at the end of life that you would highlight, but those are two that I'm aware of that are helpful, I think, for individuals who are embarking on this particular care plan.
I think one additional symptom that is common is going through a period of confusion or what we might call delirium. And that can be very confusing and distressing for the person going through it as well as the family, because, for example, they may ask for food. And so having support for the physical symptoms as well as the psychological and spiritual aspects of what's happening when a loved one is dying are really all kinds of good reasons why robust hospice support is important and applicable for someone who's going through that process.
Sorry.
Oh, I just was going to say in closing, hopefully that's a little insight into, I appreciate that there's a lot of frustration, I think, out there, not just in Vermont, but elsewhere across the country of why medical aid in dying is not an option for people with dementia. But I do think that we have other tools that can really support people well. And, would encourage you again, as always, conversations with your family and with your clinical team are hugely important to talk about in advance, and to get these preferences and priorities documented so that we have good insight into crafting care plans that are hopefully respectful of what the top priorities are for a person who's living with and ultimately dying from this disease. So thank you all.
Thank you, Cindy. I was just going to ask if anyone had any last questions because we are a little bit past 1 o'clock. I have posted some information in the chat, including the Vermont Ethics Network's website and some information on our website as well as my email address. This is being recorded, and a recording of the video will be available. It will be sent to everyone who registered, and then it will be available on the videos page of our website, and I have put a link to that in the chat. So please feel free to go back and listen and read the slides again, anything you'd like, and reach out to any of us, certainly, if you have more questions.